Thank you, and it's important to note that the Gunners got up 2-1 this morning, a goal in the 91st minute. I saw it on the train between Gordon and Kalara, so it was quite a... We still need a win this weekend, last round. We need Tottenham to lose, which for any Arsenal fan is always the case. Okay. Let me see if I can work this. That's the topic of the talk today. I'm a radiation oncologist from the Northern Sydney Cancer Centre and also Central Coast Cancer Centre as well, and some units around Genesis Care. The aspect for today's talk was basics of radiation treatment, neuroimaging modalities. I thought I'd just roll on to what's important to know, where radiation has changed, and why you should feel more confident going into treatment now. So what's radiotherapy? So what's radiation treatment? Essentially it's the use of high energy X-rays to treat cancer. The same type of X-rays you have when you get a chest X-ray, but these are more powerful. So they don't just take a picture, but they can actually damage cells. The key to it is that it's targeted and precise, and it's given on a machine called a linear accelerator. For people with gliomas in Australia, that would be probably 99.5% of the people would be treated on a linear accelerator. The treatment is individualized, so it's a treatment which is targeted to where the site in the brain is. So it's not a generalized treatment, it's actually one which requires individual planning. And the key aspect of it is that we damage tumour cells, but by giving it in certain ways, either by sparing the tissues outside of the radiation field, we can actually protect the normal cells, and by giving it slowly, we can actually allow the normal cells to repair or recover or minimize the damage. Now, that's the basis of it. I think I've jumped straight to what my 3 tips to patients are. And the 3 tips are regarding radiation treatment is 1, generally how you walk into the radiotherapy program is generally how you should tolerate it. So it's really important for John to understand that. So if you get through John's operation okay, then you generally will get through the radiation component reasonably well. We want John to take out as much tumour as possible. This is for gliomas, and the same principles apply for metastases as well. Get out as much tumour as possible and create a space, but without causing damage. If a patient unfortunately comes through an operation with damage, then they're really in more difficulty when it comes through for treatment. So aggressive surgery up front to clear out everything, if it means causing damage, will have a negative effect down the track, and that has an impact on overall prognosis. The other fact is that this is as I said, individualized treatment, so the side effects are really dependent upon what site in the brain where the tumour is sitting, and generally comes down to swelling and swelling and swelling. It's really the biggest component. So radiation treatment can make you tired and can cause a lethargy, especially when we're giving it in combination with the oral chemotherapy. But the biggest factor we have is swelling, where tumour cells, it's not the normal brain that swells up, it's the tumour cells around the area where the surgery's been or where the tumour's sitting. They swell and become inflamed. It's a process of inflammation. And that's when things like steroids, which are anti-inflammatories, come in to try to settle that down. But you can think of multiple different potential side effects of radiation, but that is really the key one. That's the one we concentrate on most. And we do our best to try to manage that and have this dance between having a high dose of steroids to reduce down swelling, a lower dose to manage the side effects of steroids, and try to find the right balance in between. With time, swelling will eventually resolve, but sometimes we don't have that time and we have to do other things. And the final tip is mobility is the key. So if I say to our younger patients, if you're not working, you're walking. You've got to do it. It's like taking your Keppra. You have your Keppra morning and evening, you'll have your walking morning and evening. If you can't walk, then we need Andrew Cole, who's talking later on this afternoon, to really work hard in rehab, or give you some mobility aids, or do something to compensate for the mobility issues. But we have to keep you walking. If you're not walking, then you lose muscle bulk. Steroids makes you lose muscle bulk. Swelling leads to weakness, which leads to increased steroids, which leads to muscle bulk loss, which increases weakness. So the key aspect is maintaining your muscle bulk, not necessarily through diet, but mobility. So if you're walking and you're mobile, you not only enjoy life better, but you'll live longer. And that becomes a key, not only for brain tumours, but also in patients with other malignancies elsewhere around the body as well. So what I thought I'd do is break down the radiotherapy pathway and where the radiation therapy comes into play along the journey that many of you are on, or have been partly on so far. And it comes down to a process of following decision-making for radiotherapy through to follow-up. And then there's 3 key steps which will help you decide, if you want to have radiation treatment, if you're offered radiation treatment, how it should be given, where it should be, etc. The 3 aspects are really target decision. You've got to map out the tumour. We've got to know where it is. That's the most important part of the treatment delivery. You don't need the Rolls Royce to deliver it. You need to have the correct road and the correct map to drive it on. So you need to map it out effectively. The next step is you've got to have really good planning. So you've got to be able to hit that target, but minimise the dose elsewhere. And the final thing is you've got to have good, safe delivery, but you don't necessarily need the Rolls Royce for delivery. So the first aspect is this aspect of target volume delineation, or just designing or working out where the tumour is. And John mentioned all about the MRI scans, and we can look at those sort of aspects. And that's much more part of what we do now. The preparation for treatment is key. Trying to get the right design of the treatment and target exactly where it is why we order so many scans beforehand. And as we go further, you'll be on the MRI machine not for 15 minutes, you'll be on the MRI machine for 25 minutes, and sometimes 45 minutes, because we're going to be doing different sequences to help map out where the tumour is. We have the ability to target the treatment now and hit that area, but we've got to scoot the dose around normal tissues and reduce the amount of good normal brain we're treating. So we use a combination of MRI scans and PET scans. I don't have a pointer, so it's going to be quite difficult. Anyway, so basically, if you look at the MRIs, you point out that John showed beforehand, that's on the far side. That gives us a clue where their tumour is, but there's a bit of grey here, a bit of white there, a bit of grey there. Then we need other sequences of the MRI to determine what's tumour and what might be scar tissue or inflammation. And we also do PET scans, which can potentially, if we're lucky, this is a PET scan for a meningioma, which can light up right where there are sites of residual disease. And then from there, as a radiation oncologist, we can try to map out the extent of the tumour. They don't grow like that. They don't grow like spheres. They grow along pathways in the brain. They grow asymmetrically. So as John pointed out there, the tumour from the lump might be 4 centimetres away, but it may be 4 centimetres away in a certain direction. It may not be 4 centimetres away all around the tumour. So part of the clues that we've got to work out is find out where things are going and try to track where that tumour is heading. And then if we can track where it is and we know where it is, then we can deliver a dose which is pretty much confined to that area to a high dose. So we need the knowledge. And this is where we're really changing a fair bit. We're getting much more better understanding of the way that the tumours move in the brain as we're seeing better and better MRI imaging. That's an example of a DTI and tractography. So where the textbook shows where things are. Second slide is one of our patients with a tumour there. And the third slice is right where the tumour is growing. It's growing right along one of those green roads or blue roads that we're seeing there. It's not extending 5 millimetres that way, but it's extending 4 centimetres in that direction. So that will allow us not to treat large amounts of brain, but to work out exactly where that tumour is going and hit that area in a much more sophisticated manner. And that leads to that second factor, which is the planning. And that planning is trying to design the treatment and push the dose right where the tumour is, but spare the normal cells. And so this is an example of just what modern planning does now. In the old days, when we used to treat patients, we would like to have a nice even dose across the whole tumour area. You didn't want what we used to call a microwave oven effect, where you heat up something and you get a bit of hot here and a bit of cold here. That was deemed to be bad radiotherapy. But now in 2021, we're managing patients with hot areas here, colder areas here, and we're getting more clues from the MRI as to where to deposit dose. And at the same time, swing that dose away from the good cells and the important structures in the brain. We can allow some of these structures, and so right in the middle there, we've got the brainstem, so allow the brainstem to get part of the dose. It can tolerate that, but we don't want it to get the really high dose. So right where that red is merging into yellow, in the past, to deliver with a standard treatment, it'd all be blue, and you'd be underdosing the tumour in that area. So the technology has changed, not on the machine, but in the software to allow us to hit that area. We're still using the same recipe, but we're getting better dose in, and soon we should be able to push that dose up a lot higher. And what we do, what we call dose escalate the area, so give a higher dose. When we first started treating prostate cancer, when I was a specialist treating prostate cancer, we used to give 60 units of radiation to prostate cancer. We now give 84. And our results with prostate cancer have improved. In the brain, we're nervous about that because of swelling. So if we can manage the swelling better, then we can potentially push the dose up a bit higher. And the technology and the imaging is allowing us to do that. So that's an example of what I used to do. So I'm a fairly young man. And I used to do this to people back in my first job in 1996 as a specialist, where I couldn't order an MRI. I wasn't allowed to order an MRI back then. We had to admit people into hospital to get an MRI done. And then we used to do a plain X-ray, and then we get out the old protractor and draw circles. And it'd be one beam there and one beam there, and that'd be it. Then we got smart, and we went to 3D conformal. And I was really proud of this. I actually got this off a slide of emerging technologies, a talk I gave in Shanghai in 2004. And I was really proud of that slide. But also what that showed was that there's a lot of blue on the other side of the brain, and the shape of the red is pretty much a rectangle. Tumours don't grow as rectangles, but we're treating all that area to a really high dose. We've gone from 3D conformal now, which used to take a therapist manually 24 hours to do. Now we go through to what we call intensity modulated radiotherapy, where we can design whatever we want and they can punch that out in an hour. And we've actually got machines now which can change the plan on the bed whilst you're just based on an image done on the bed. So it can be changed within 3 or 4 minutes. So we're able to now push dose into areas of the brain where we couldn't before at a higher level, and also protect good areas. So we can design the treatments in different ways. And that leads to a lot more potential options in the future for our patients with dose escalation based upon interesting aspects we see from PET scans and MRIs. Our key is not to improve the radiotherapy machines, but to get the MRIs better and to get the PET scans better and to get those metabolites that John was talking about in a better way. The final thing is the machine. And I'm going to be a bit derogatory here because everyone looks for the machine. The machines are high quality. In Australia, we've got a national organisation which every year checks your machines to make sure they're delivering a really accurate dose. And every day, the physicists in the department check the machines the machines can deliver things much, much better than what they could do in the past. But the machine technology is just about there. It can do more interesting things for targets that move on the bed, but brain tumours don't move. The key now is actually the step beforehand, making sure we're hitting the right areas. So that is a standard linear accelerator. That's one at Gosford Hospital. So most of the work for linear accelerators now goes into the roof. You've got to make the ceiling look nice because the machine's pretty much the same. And so 99.9% of our patients across Australia will be treated on a linear accelerator. It has the ability to do a CT scan on the bed, and it gives the beam very accurately. That's a gamma knife. So gamma knife is a really novel, interesting machine that came through from about the 1970s, and there's two in Australia. Gamma knives are really good for very small targets. The linear accelerator can treat those very small targets as well, but it also treats the workhorse. This very small target treatment is what we use for brain metastases, and that's called stereotactic radiosurgery. The gamma knife is a machine dedicated for that. And basically, you screw a head frame in, and the beams just, they're radioactive sources that allow a beam to go straight through, and you can target it very much into the centre. But the other machines can do that as well. This is really good if you've got Parkinson's disease or if you've got some sort of pain neuralgia where you can give a really, really, really high dose to try to destroy that part of the brain. Not a lot of additional advantages over standard linear accelerators for brain metastases, and no use in gliomas because the targets are too big. That's a proton machine, and they also look really good too. And there's one coming in Adelaide in 2022, and the federal budget just pushed up a little bit more funds to pay for patients to have that. Protons probably don't have a great role in gliomas. We thought they would, but it's going to be a fairly limited role, if any. And I don't think the Medicare indications will cover proton therapy for gliomas up front. Protons have the ability to dump the dose very quickly and then drop it off very far away very quickly, so getting minimal dose to your normal tissues. So the one over there shows the red circles as we saw before, and the rest of the brain looking pretty clear. That's what a proton does. The IMRT splashes a bit of dose in the surrounding brain. But protons have a bit of an issue because you're pushing it all in one area. So for people with brain tumours, there's probably going to be a higher risk of permanent hair loss on that side. And also, we're knowing from what John was saying, we need a bit of dose going down those tracks and pathways. And so if we cut it off, then we're probably not going to be able to deliver that because we're not getting some of the advantages we get. The bottom line is that these machines need smart humans to run it. That's where the key is. So what's the most important parts of that pathway for you to understand? For patients with primary tumours, it's really the target design and the follow-up. The follow-up's the key. I can design treatment, and to design a course of treatment, for me sitting in front of a computer for about an hour just doing a whole lot of drawing in different colours. But the key in longer term, and the most time we spend with our patients, is actually working out what that swollen area is in the brain, and if it's tumour regrowth or if it's just a whole lot of swelling as a result of the treatment. So we have to map it out to where we've been before. The poor radiologists see your scans after treatment and just scratch their head. They don't know what's happening. So you actually need your radiation oncologist or your medical oncologist or your surgeon to interpret and understand that. And we see bizarre things in the brains. This is not an unusual thing. This is a patient going from left to right over time, and she's got a swollen area near the surgical cavity that came up. We thought it was going to be recurrence, and then disappeared. It was just swelling. It got better on its own. Or we have to treat a big swollen area with a drug called Avastin, which helps to get it down as well. But we need to be able to interpret those changes. So follow-up is the key. For patients with brain metastases, it's more about the decision-making up front and also getting the software right, so you're hitting that area and sparing the surrounding brain. So with brain metastases, we used to treat everyone with whole brain radiotherapy, which, if they had one or two lesions, they would get the whole rest of the brain managed. But that whole brain treatment often led to late side effects where there was scar tissue in the brain. So we've moved away from that now, and the key now is to just spot weld the lesions as they come up. And it might mean that in one sitting you just have one treatment to 2 lesions, and then you come back a month later after another MRI, if there's another one, you spot weld that. And you manage patients under a policy of whole brain radiotherapy avoidance. And we've got some really, really nice software which can do that now, where patients used to be on the bed for about an hour to get 5 or 6 different lesions treated. Now it can be all over in 10 minutes. So, and without any need to screw a head frame in, you could just use a basic mask. So that's the pathway for radiotherapy, and that's the roles that we see in radiation therapy across the continuum of how we treat people. And I guess part of it comes down to knowing that things have changed over years, where those initial images, when I was a young man treating people, targeting in that area there, we're now basing some of our decision making off the results of those treatments. So late side effects in the brain are based upon old studies performed in the 1990s. We need to move along that and gather more information, use the good imaging to help design our treatments, and get up and coming information about how our patients are managing or functioning in the years after treatment. And that was from last Saturday's Loonig, which was probably a bit about decision making. Which way? There must be a path there, and hopefully these sessions will help people decide which is the most appropriate way for them to be managed. Thank you.